Ashok Dutta. May I now request Dr. Ashok Kumar Dutta to have his presentation on steps of decay crash. Dr. Ashok Dutta, Professor of Cardiology from National Heart Foundation Hospital and Research Institute.
Thank you, Dr. Smith. So, respected panel of experts, my dear teacher and audience. My topic is decay crash. Decay crash is the double kissing at the same time, double crash also in the bifurcation stenting. Already TAP and culotte described. In the TAP and culotte, you can do it as an upfront technique or as a bailout, but decay crash is always should be done in upfront technique also. So this is very short in chronological history of crash. 2003 classical crash, then decay crash 2005, and that was original, where the pertusion of the side branch stent was 3 to 5 millimeters. So there will be 3 layers in the distal part of the main vessel. And subsequently, contemporary decay crash that we are using now, that protrudes only on to 3 millimeter of the side branch stent, reducing the amount of metal mass in the distal left main vessel. And if side branch is 3 or more than 3 millimeter and protrusion is 1 or 2 millimeter, there will be 2 layers. If you see here, there are only two layers of metal. So that reduces the metal mass. In the same idea, now what Jamal sir was telling, mini culotte and decay mini culotte is now invented. So these are the steps of decay crash. There are 4 steps that is essential component of the decay crash. 2 crash, 2 kissing, at least 1 pot, or most importantly, if you can do the repot also, that is also important. So 2 kissing, 2 crash, and 2 pot, these are the essential component of the decay crash. So with this, I like to present the case of 55 years presented with ACS during that was during the COVID period. There was mild hypokinesia of the anterior wall. So this is the ECG. There was some STT change. And this is the angiographic report. Severe left main disease, LAD, LCX, ostium also disease, so Medina on. RCA was codominant, no collateral to the left. So this is the unprotected left main disease. So there are 3 advantages of decay crash. First, left main to LAD wire, you never have to lose this wire. Second, side branch, there is little or no possibility to lose the side branch. That is the controlled procedure. And regarding size of the side branch and the main vessel, regarding the angle, this is an universal technique. So first is the wiring of the both LAD and LCX, then predilatation of the LAD and left main. Patient become unstable at this stage. So we did not do the IVAS at this step. So stenting to the circumflex rapidly done with 3 or 18 millimeter with 1 to 3 millimeter, usually 2 to 3 millimeter pertusion, and with keeping a balloon in the LAD. That is important also. Otherwise, subsequently, you cannot take the balloon for crashing of the LCX stent. So this is inflation. Oh, sorry. So then pullback stent and high pressure crash is done. Oh, there is some problem. Oh, no, that's not. So after wiring to the LAD and LCX, that was definitively 7 French guide catheter should be taken for decay crash and nano crash when you used to take 2 stent at the same time. So after pre-dilatation, we took the stent in the LCX, protruding about 2 to 3 millimeter in the left main, and balloon in the LAD. So there may be question whether you took the balloon first or whether you will take the stent first. I usually take the stent first, then take the balloon to the LAD. So then we do the pullback after putting the stent in the LCX, pullback of the stent balloon and high pressure inflation. This is not essential. Sometimes somebody tells us it may affect the subsequent crash, so better not to do the pullback and high pressure expansion. And if then a balloon from the LAD, stent is crushed. Definitively before crushing the stent, we should pull out the LCX balloon and LCX stent. And sometimes if the LAD is very much big, then a step up crush with a bigger size balloon may be essential. So now recrossing like that, different from the tap and other technique, non-distal recrossing is essential. It may be done with the workhorse wire, and if workhorse wire does not work, you may need the polymer jacket wire with the help of microcatheter. So this is the first case with the balloon in the LAD and LCX. Simultaneously it is done. At higher pressure, usually 12, but sometimes you may need to go up to 18 ATM. So after doing the first case, LAD to left main to LAD stenting, then proper positioning of the stenting is very much important here, especially when ostium of the left main is covered. Allocranial is the best view to see the ostium of the left main, and a cuspal wire. And sometimes if you see any calcification at the in the aorta, that may help you to put the stent perfectly covering the ostium. No more hanging, and definitely ostium should not be missed here. So stent inflated, then pull back and high pressure inflation at 18 ATM. Now port is done with a bigger balloon, and port should be done very correctly so that carina is not deformed by the port balloon. Now guide catheter should be engaged properly so that subsequent wiring become easier. Then second wire recrossing similarly in the mid start or proximal start. Otherwise, there is chance of miss at the carina. Geographically, that may be missed from covering by the stent. Then opening up the start by progressive dilatation of smaller to bigger balloon. Then catheter alignment and support is very much important here. Then up. So final. So this is the semi-compliant balloon or NCB. Then report, this is the final port, and definitively imaging is important. First IVUS, and subsequently we did the OCT also. One important thing for OCT or IVUS is the carina. Here the left main area was more than 11, and LAD dia was 4.35, and this is the inner view. If you see, the carina is very much important here. This is the LCX. And in cross-sectional view, the carina is oil formed. If you see here, so OCT or IVAS both are important, and IVAS pull from the LAD to left main as well as from the LCX to left main. Both pullback is important to see that.
Thank you, Ashok, very much for your vivid description of decay crash technique. So I think we're close now. Next quiz.